Hi, everyone. Thank you so much for joining us today for this speaker series. We are very fortunate to have a great guest here. So I'll start with an introduction of myself. So I'm Dr. Jessalyn Holodinsky. I'm a researcher in the Department of Emergency Medicine at the University of Calgary, and I'm also a faculty member of the Center for Health Informatics. At CHI, we focus on all aspects of data pipelines, like from data collection to analytics and then custom displays. Our goal really is to transform health data into meaningful evidence for the community, and working collaboratively to help develop, innovative methods in health informatics to support precision health. The speaker series that we do is really to highlight the exceptional work of our colleagues in the field of health informatics. And today we're really fortunate to have Dr. Jennifer Vena with us. Dr. Vena is the scientific director of Alberta's Tomorrow Project at Cancer Care Alberta, where she guides the scientific and strategic direction of the platform to support research in cancer and chronic diseases. She also contributes to the National Research Platform CanPath and holds an adjunct assistant professor appointment both at the University of Calgary and at the University of Alberta. Her research focuses on nutrition and metabolic disorders with attention to ethical and privacy considerations in healthcare data. So we're very fortunate to have Dr. Vena here. I will ask you if you have any questions to please put them in the chat and we will answer them after the presentation is over, or when the presentation is over, feel free to use the raise hand function and we'll come to your questions. And with that, the floor is yours, Dr. Vena.
Perfect, thank you. Just let me know when you can see that.
Perfect, looks good.
Perfect. Okay, great. Thank you so much. I'm thrilled to be here and really looking forward to discussions today and going forward, and hopefully making some new connections and partnerships. And before we begin, I just wanted to extend my condolences for the loss of Dr. Huda Kwan. He was a really lovely and generous man, and we didn't get to interact a lot, but the times that we did, he just always was so thoughtful and kind and generous in his knowledge. And so I really feel for the entire Center for Health Informatics team. So what I'm going to cover today is just a little bit of background about Alberta's Tomorrow Project, talk about some data linkage opportunities and examples of the data in action, and then talk about data access. And I'll try to cover some areas of shared interests, I think, that we have with members of the Center for Health Informatics. So I don't really think I have to convince anybody here that cancer and chronic diseases are a significant burden in Canada and elsewhere. And so we really need to understand how we can better screen and treat people, but also how we can really try and prevent as much as possible. And this is really complex because life is very complex and the various things that we are involved in and exposed to. And so it is quite complicated to understand comprehensive risk. So large population studies are one tool in the toolbox. And so how do we better understand risk? Well, we recruit a large number of people, ideally before they have disease conditions. We collect information on them, and then we follow them over time to see who develops certain diseases and who doesn't, and then explore why. So Alberta's Tomorrow Project is one of those cohort tools in the toolbox. It was started back in 2000, really as a pilot to see if people would sign up for a longitudinal long-term study where they might not get any personal benefit out of it. The enrollment criteria was pretty broad, really age 35 to 69, living in the province of Alberta, at least for the next year, able to complete questionnaires in English, and then no history of cancer other than non-melanoma skin cancer. But other than that, wide open. Participants were asked to provide information and consent to follow up over time and allow their information to be used for research. They were also asked to give consent to be recontacted for future data collections and for linkage with administrative health records. So We recruited over time, and by 2008, we had 30,000 people enrolled from across the province, all across the province. And at that time, there was a push to create similar cohort studies across the country, and these collectively came together to partner on efforts and data collections. And this is the family of cohort studies is called the Canadian Partnership for Tomorrow's Health, and I'll talk about that in a minute. So when CanPath started, we invited existing participants to come over to that study and be part of ATP and CanPath, and we also recruited more participants. So in 2015, we closed recruitment with almost 55,000 people enrolled, and began to, now follow them over time. And we also put on our other hat, which is the data platform hat, and started making data available for access and request. And the map here just shows you the locations where participants were recruited at baseline. So you can see that it really is spread all over the province, which we are quite proud of. Go. So like I said, CanPath is a family of cohort studies. Now there is one in every province in Canada. The original 5 were BC, Alberta, Quebec, Ontario, and the Atlantic provinces. And since then, Manitoba has joined, and Saskatchewan is actually still recruiting. So if you have any friends, family, relatives, etc., in Saskatchewan that might be interested, please let them know that there is a big cohort study that is actively recruiting there. So collectively, this represents over 330,000 Canadians, 7 cohorts across 10 provinces, and I think the big effort is in harmonizing data collections as much as possible so that it's apples to apples across the country. And you guys are all data people, so you know how important data harmonization is, and really having power in numbers. So when we want to look at maybe rare conditions or things like early onset cancers, where you typically have smaller numbers, the national landscape can be really helpful for this. And so briefly, at baseline and since then, we've collected our data through health and lifestyle questionnaires. These started as paper and pen and now have moved fully online, but basically trying to collect as much information as possible about risk factors across a broad range of domains. And I think importantly, these are data that are not typically found in administrative records or other databases, so they do they do represent a very unique and valuable source of information. So we try to do a very diverse collection that stays the same for some elements and evolves over time as well. When CanPath started in 2008, we also received funding to do collection of biosamples and physical measurements. And so this was achieved through static study centers that stayed put in Calgary, Edmonton, and Red Deer, but also mobile study centers that were basically all the supplies needed packed into vans and driven across the province and set up in community centers and rec centers and hotel ballrooms and things like that, with everything needed to process surveys and take blood samples and do physical measurements. And so we actually have at least one of our staff who is involved in some of those mobile study centers, and I can see Kathleen Murdoch on the call. So if we get any questions, I might field those to her. But this was a really creative, I think, endeavor. Huge endeavor. But as you can see on the map there, these are all the locations where study centers were held. And so it really enabled us to get not only the data, but the biological samples from people all across the province, from very northern to very southern, so that now we can also look at metabolic health and things like environmental exposures or other things that might be unique to areas outside of our major urban areas. So we collected fasting and non-fasting blood samples as well as urine in the study centers. And then for people who couldn't or didn't want to come in for a visit, we collected saliva by mail, and that's primarily used for DNA. And then the physical measurements were things like body fat, blood pressure, grip strength, height, weight, and waist and hip circumference. And the majority of our blood samples were frozen at -80 within 2 hours of collection, with the remainder frozen within 24 hours. So this was a incredible quality control, I would say, and to the extent that there were literally portable -80 freezers that plugged into the car lighters that actually facilitated a lot of that. And then this is our new biobank space in the Arthur Child. They affectionately refer to it as the biobank bowling alley, and actually each of the freezers has its own name after a character in Frozen. So if you ever want a tour of that, let us know. And then from the 30,000 people that we have biosamples on, we received funding in 2017 to actually measure clinical markers on all of them. And that was done through Calgary Lab Services. So the list is presented here. But I think that's a really unique resource too, because we can do linkage to lab data. But you're relying on people who have had an encounter with the health system and gotten things measured. But this also gives you data from people who may not have, and also a source of control participants. So if you're looking at certain outcomes or people with, say, cardiovascular disease or diabetes, you can look to Alberta's Tomorrow Project, not only for cases, but also for groups of control participants as well. And then, so since recruitment ended in 2015, from the participant side, we've entered our follow-up period, and so we've had periodic, sort of large cohort-wide data collections by surveys again, and done some sub-studies with biosample collections related to microbiome and then COVID-19. And then we have a couple of projects going on right now, which I'll just talk about very briefly. Including radon and diet and activity. So radon, we're looking at, because radon is the second leading cause of lung cancer behind tobacco, and it is particularly high in the prairie provinces, so it does reflect, a particular Alberta concern. And so we're working with the Evict Radon National Study Group from the University of Calgary to do a multi-part project. So the first phase was doing a comprehensive lung cancer risk questionnaire or survey in all of our participants, and that was completed last year. And then from that survey, we have invited 5,000 people to do radon, or 5,000 participants, sorry, to do radon testing in their home, and also collect toenail samples for eventual measurement of radon decay products to use as a marker for radon exposure, so that you don't actually have to do radon measurement in your home. And the toenail samples could also be used to look at heavy metal exposure. And then the last part of it is we're going to be asking participants, some of our participants who maybe are in both ATP and the Evict Radon project, to sign a consent to allow Evict Radon to send us their radon-related data. We can pool it with the ATP data and make that more broadly available using our platform to really make that available to anybody, any other researchers who want to access that data. Okay, and then the other one we have going on right now is around diet and physical activity. So this is funded by a CIHR grant to Rachel Murphy, who's at UBC, and Sharon Kirkpatrick, who's at the University of Waterloo. They are both experts in nutrition, epidemiology, cancer prevention, and nutrition assessment. And so the grant itself really aims to look at associations between the retail food environment. So how close are you to grocery stores, and what kind of foods are there, and convenience stores and things like that, and diet quality. And this is facilitating data capture from across all of CAMPATH, so all of the cohort studies that are involved. It's a really comprehensive data collection, and it will be the largest data collection of its kind in Canada ever. And we are also linking all that diet and activity data to Canoe, which is some built environment data, which I'll talk about a bit later, as well as CanFed, which is a Canadian food environment data set. So I'm not going to spend too much time on this, but if you've ever tried to do anything in the diet and activity world, it's just very difficult to do it well because we don't always eat the same things every day or do the same things every day, and we're influenced by lots of different things. And there's different ways you can measure diet and activity, and they all have pros and cons, and there's no one tool that's going to give you everything you need. So I like the analogy of good, fast, cheap, and you can usually have two of those things, but never three. So if you want to do a really comprehensive data capture, you need to use multiple tools together in order to maximize the strengths and offset the limitations of each. So, like I said, it's a pretty big endeavor. We're going to be asking participants to complete multiple different kinds of tools for diet and activity capture over a year, so that we can get comprehensive data and also be able to pick and choose the types of tools that we use in the future and have data to validate it a little bit. And I think importantly, so again, all of the regional studies are going to be doing this, and we are all using the same survey tools so that data harmonization will basically be baked in to this process, which again, I know you guys will appreciate because trying to do it after the fact is messy. So that's going to take us a couple years to do the whole capture, and people are being spread out over time, so that's going to impact it as well. But I also wanted to mention that study because we are actually working with folks from the CHI, and I can see Chelsea's on the call as well. So back in our early days, we used the past year physical activity questionnaire, which was developed by Christine Friedenreich. Basically asks you your main activities for the last year. It's meant to be, kind of a comprehensive capture. It was designed and implemented as a paper-based tool originally, for lots of reasons. As you can imagine, we cannot do that anymore. So we need to have it as an online tool that we can implement here at ATP, as well as have all the other CAMPATH cohorts do as well. So we're working with the folks at CHI with Chelsea's group to produce it in REDCap because they have the expertise to do it very, very well. And we're going to try to make it as participant and administratively friendly as possible to do that data capture. And it will basically be built once and then sent to the other regional studies to implement in their systems, so that again, data harmonization and similar data capture would be built into that process. And then this is also a questionnaire that we would look to make available to the broader research community upon request. We can't really hold it and host it, but we could potentially, if people are interested, we could make it available as well. So we just wanted to thank the CHI group for their partnership, and it's been really great working with them so far. So we look forward to starting that project soon. Okay, so data linkage, like I mentioned, participants consented to data linkage, actually almost all of them. So data linkage is great because for us, it allows passive follow-up of participants if they have passed away or they are not participating or they're not really involved with the study anymore. They're not responding to surveys, so we can still look at health outcomes. We can look at incidence of disease, how they're using health services, and not have to collect that information from them directly necessarily. And it can be just a different and reliable source of information like medications and dosages and things like that. So we link to other data sets using their personal identifiers and sometimes postal code. So I know this group is really quite savvy with data linkage and the various particularly administrative data sets that are available in Alberta. So I'm not going to spend too much time, but I'll fly through the ones that we typically work with. So predominantly, a lot of our requests are for the Alberta Cancer Registry, so for cancer outcomes, because we were really initiated as a cancer prevention study. So the cancer registry data, actually, we have a linked copy sitting with us, and that is data that we can send to researchers directly, which is great because it makes it a really fast process for us to give you survey data and cancer outcome data. We don't have to do anything else for linkage or go through a different custodian. We also have a process in place with the Alberta Cancer Research Biobank. So if you don't really know about them, they collect data, clinical data and biosamples from people at the time of a cancer diagnosis. And predominantly they've been like mostly project-based funded. So we did look at how many participants we have in the Cancer Research Biobank just by happenstance, and we had about 400 people who would part of ATP, so they would have probably provided a biosample to us sometime before cancer diagnosis, and then also have tissue or blood or something available in the biobank, in the Cancer Research Biobank, at time of diagnosis. So now you have a subset for whom you could do some longitudinal or paired analyses. We're also involved in DECIDE, which is the Data Environment for Cancer Inquiry and Decisions. So this is an initiative from what was Cancer Research and Analytics, and it was really to try to bring all cancer-related data together, especially with Connect Care and the EPIC system coming in. A lot of data structures and systems were going to be broken anyway and would have to be rebuilt because the way the data is coming in was quite different. And so there was a cancer leader, Nancy Giebert, who used to say, "Never let a good crisis go to waste." And so they, this was the brainchild of Paula Robson, who is the scientific director for Cancer Research and Analytics. And so they were basically rebuilding this system to bring all this data together and have it linked, pre-linked, so that data is updated in real time. You don't have to do ad hoc linkages every time somebody wants some new project. All you would have to do is take the linked data set and pull out what you need. And so we are being incorporated into that. And this now sits, I think, really with Health Shared Services in close proximity to Safford Dean's shop and the Enterprise Data Warehouse. So we're looking forward to be really integrated into that and to be able to use that to provide data to researchers in a little bit more streamlined way. We can also link to the Alberta screening programs to get information on screening uptake and results. And we've had a couple of opportunities to do that so far. And then largely we work with the SPORE support unit for facilitating really the rest of our data linkage requests for researchers and getting administrative data linked to our survey data out. So we have a really great working relationship with them and have streamlined a lot over the years as well. And they're also wonderful. So yeah, for everything, including surveillance, and then we can also do linkages with the Alberta Precision Labs and other things. So the last one I'll mention that people may or may not be familiar with is that CANU data set. It's the Canadian Urban Environmental Health Research Consortium. And so they have generated neighborhood level, a variety of estimates actually based on the neighborhood level postal code. So things like material and social deprivation, air pollution, green space, noise, lots of different things, and they're always adding components as well. So we can link that using our participants' postal codes, including over time, so if they move locations. And so this can help you get insight into how other environmental factors are linked to health outcomes. And again, that data is held right at ATP, and we can share that directly. So no other like linkage or hoops is needed for that. And then finally, sort of in the way of data linkage, we have the CAMPATH data set. So like we said, we harmonize the data collections. We try to align as much as possible. And Maelstrom Research is the group that has done the harmonization for all of the regional cohort data. So CanPath itself holds a big de-identified copy of all the survey data used across the studies for people who consented to be part of CanPath. And so you can request that directly from CanPath. They also have a synthetic student data set. So this would be something that mimics but doesn't include real participant survey data. And that is actually free for use in academic courses. So you still have to apply to use it so that we know who's using it and doing what with it, but it is free to use, and that's directly from CanPath, which is a wonderful resource. CanPath and all of us work very closely with the Health Data Research Network to support research requests that come in that want to use data from across provinces, so BC, Alberta, Ontario, for example. And then we are working with CanPath to explore linkages with CIHI, the Canadian Institute for Health Information, to have a set of administrative data linked to the health and lifestyle survey data that actually sits at CanPath, and that CanPath is able to share with researchers, again, trying to reduce the administrative burden of requesting linked data and data from multiple sources. And then we're also in the process of exploring linkages with Statistics Canada and potentially having some CanPath or say ATP data sit in a Statistics Canada environment and link to the data sets that are available there, again, to try to facilitate easier access to data. So I wanted to give you a couple examples of how the data has been used. This is very quick. It's not exhaustive by any means, but hopefully will give you a flavor. So the use of our data really has grown over time. We get increases every year, which is fantastic. I mean, this is a provincial resource for you to use. So we really encourage you to take a look. If you want to see more information about how the data is being used, particularly if you're interested in a certain area, you want to see if something's already been done, you can come to our website. We have all the approved projects on there and any publications coming out of those approved projects. So we do update those periodically, and it's all publicly available to see. So a lot of our data has been used for cancer risk and prediction, sort of across the board, from screening to early onset to stage of diagnosis for different types of cancers, as well as chronic diseases. So everything from cardiovascular disease, including hypertension and cholesterol and cardiovascular risk prediction, mental health, and even neighborhood design and green spaces and walkability and things like that, and how that relates to metabolic health. So one study I wanted to profile, this is through a partnership that we have with a group at the University of Alberta with Dr. Jeff Johnson, Dean Urick, and Ming Yi. So they hold a very large ATP survey data set linked to administrative data from Alberta Health, or whatever it's called now, with the data there. And so they have produced a number of studies based on this linked data set, really to showcase the value and utility of having these two different data sources brought together. So as an example, previous studies using only administrative data health records suggested there's an increased risk of diabetes with antibiotic use. But they, being administrative data sets, they weren't able to include a lot of important confounding factors. So they took the ATP health and lifestyle data, like comorbidities, family history of diabetes, sociodemographic factors, body size, diet quality, and physical activity, and linked that to administrative data to look at incidence of diabetes and history of antibiotic use. And so you can see here that when they just use the administrative data, it does look like there is an association with antibiotic use and risk of diabetes when you can control for what you can from the administrative data. But as you include more of the lifestyle and other confounding factors, the data that's available really only through cohort studies like ATP, that risk was progressively reduced the more you accounted for these other potentially confounding factors. And so I think this one is a really nice one of showcasing the value and utility of adding this data and this perspective to the administrative records. And so I know this group has some broader interests in cardiovascular disease, so I'm not going to go too much through this, but just that we can do case counts through the linked administrative data, and we can also look at self-reported data using the survey, and provide you with estimates for proportions of risk factors and things like that. We are increasingly creating quick one-pagers to give you a quick snapshot of other data that's available that you could explore and some sort of quick facts and figures. So I'm happy to share some of these after the talk in a follow-up if there's interest in that. But just to give you a flavor that, you know, we do have quite a lot of data, and we can obtain a lot from the administrative data sets as well. And so we can try and provide you with some information so that you can take it away and see, like, okay, is there something here that I want to look at? So same thing with the GI conditions. You know, we can give you a quick snapshot of what would be available. And so I want to also thank our research and data access team for preparing these high level summaries. They're a great resource. They can answer a lot of questions. And particularly with GI, we have, of course, the blood samples we collected at baseline, but through 2 sub-studies, we also have stool samples. So this might be of interest as well. Okay, so now I'm going to talk a little bit about how you actually access the data. We have our main ATP website here, and this one is really more for participants, but you can navigate up here to for researchers, and that'll take you to myatpresearch.ca. And here we've tried to provide lots of information for you to self-serve a little bit and find out more about the program and what's available. So like I said here, research projects will list all the approved projects that we currently have and any publications that have come out of it, so you can see what's already been done or is ongoing. And then under data information, there are all of our data dictionaries for the data that's available, some summary tables, which we're working to build out. You can look at actual copies of the surveys if you're interested to see specifically how something was asked, although you can find that in the data dictionaries as well. And you can do variable searches to see, you know, if I'm interested in smoking, I can type in smoking and then see all the times that it was asked over time and in what ways. So how our general request process works is that ideally you come with a feasibility inquiry, sort of an informal discussion. We can help you figure. It's really to help figure out, like, do we even have the data that you would need or enough sample size, etc. And it also helps us sort of start conversations with other data custodians for linkage if we need to. And then if and when you're ready, you would do the actual application, which requires a proposal, what you're going to do, what data you need, what you're going to do, etc., ethics approval, proof of funding to support the project, and then a CV from the primary applicant. And I would say, like, we're happy to look at your proposal or even your ethics application before you fully submit. Because this might save a little bit of time than getting all of that, and then, you know, we have suggestions or changes to be made, etc. So feel free to come to us before you fully submit. After you apply, it undergoes a review by an access committee. We really are looking for the rationale, the ability and expertise of you and your research team to do the work, and the potential value and impact, and really any risk involved. And then we also start coordinating that data linkage if applicable, again, largely through SPORE. Once it's approved, we do the legal agreements, we do the data and biosample access fees, and then we would get your data ready. So we prepare a de-identified data set, and this includes support materials like data dictionaries. We're also working on making user guides available and all of the linked data. And that is sent to you as a data cut, which I'll talk about in a little bit. And then afterwards, there's always stuff afterwards. So this might be you realize you want more data, or maybe you want updated data. So if we've done an updated linkage or something, you might want updated cancer cases or cases of diabetes. If you want to change your research proposal, so say you have a data set and you're predominantly looking at diabetes, but now you want to look at cardiovascular outcomes, usually we prefer actually to just modify your proposal and your ethics instead of having to go through a reapplication process. So we're quite, I think, flexible on that. We just need to know about it. And then we do ask for progress reports. So what's required from you is to really agree to return any new data. So that can be from biosamples you've analyzed or deriving data like risk scores or indices or whatever from the existing data. And the idea is that this data gets added back into our repository and made available for others to use. This is after an agreed upon embargo period, so that make sure it protects the data for you to publish before that's made more broadly available. And then, of course, we also ask for the code for how you derive the data, or how you the methods and quality control, etc., for if you've analyzed the biosamples, so that we know and potential users know how that data was generated. And then we ask you to provide annual progress reports, and we have templates for that. And this is important because we use these as metrics in order to sustain ATP's funding. So we do ask that you try to do those. And I think importantly, on any kind of publications, like, we don't require authorship. We're happy to contribute, or if you think we could bring expertise, we're happy to be on the study team, but we really don't have to, and we don't require that. We do ask you to send us publications before you submit them to journals, though, and that's really just to make sure that how you're describing ATP and our methods are accurate, that you've included the appropriate acknowledgement statements, and if there's anything that might impact the reputation of us or our funders. That's really all we're looking at. It's not a scientific peer review. Okay, so if you are ready, we do have an online researcher portal where majority of this is managed, again, trying to simplify the process. So you would register for a researcher portal account, fill in your information, set up an account, and you basically have a dashboard where you can manage multiple projects, team members, all kinds of things. It has the feasibility form built in there. So again, that's your first step into us. We also use this if you want a letter of support for a grant application. We ask that you do this. It just gives us some basic information to use for the letter of support. And you can upload all of your information here, like what I was saying, the proposal, the ethics approval, proof of funding, applicant CV. You'll go through and select all your variables. So you can do that all within the portal, and upon approval, it'll auto-generate your specific data dictionary. And then it also has those after approval items that I was mentioning. So if you want to request additional variables, you can submit your progress reports. We also have what we've called an alternative research output. So if you have something other than a paper, we definitely want to hear about it. Like if you have, like Jesslyn was mentioning to me before, if you have a podcast where you talked about the research you're doing, if there was a blog post, if there was a news article, if you, I don't know, produced an infographic or something, like that's wonderful. We want to know about those things. And yeah, sending copies of your papers so we can check them, and then any other significant changes. So that would be, say, if you want to now look at something else with your existing data set, that's where you would apply to do that. So we're trying to make it as much of a one-stop shop and as much digital as we can, so you're not editing Word documents and sending them back and forth. Okay, so cost and time for data. I know a lot of people are interested in this. So our cost recovery fees are set in alignment with our CanPath family. And I will say these are subject to change. So, in a month or so, these may be different because we're coming up to the end of the fiscal period where we usually look at them. But basically, there's a $500 application fee, and then the cost for your first data set is $3,000, and then every data set after that is $1,000. So if you request baseline data, that would be your $3,000, and then you could request 2 follow-up surveys, and that would be $1,000 each, for example. We do have some different fees for graduate students, postdocs, and early career researchers. And then we have a miscellaneous fee, which we sometimes have to apply if you want a really complicated data set, or if the linkage is going to be really complicated, sometimes we might have to apply that. We can't do anything about administrative data set charges, if they have any. And you can submit a cost estimate request anytime for a fee estimate, for grant applications, or for whatever you might want it for. The time it takes to get the data really depends on what you're trying to do. So if you have a complete application with all the info we need, and you're only requesting data that we already hold, say like the cancer registry data or the canoe data and all of our survey data, it can be 6 months from the time you apply to the time we send you data. It can even be as fast as 3 months. So that's probably our quickest. If you want linkage to other Alberta data sets, usually 6 to 9 months. Again, if you're based in Alberta, that tends to be quicker than if you are outside of the province. And if you are requesting biosamples, it can be about a year, maybe more. It's really variable. And this just is related to how complete the application is, how defined your, say, case control matching is, your inclusion exclusion criteria. The biosamples do undergo more scrutiny in the access review because they're a non-renewable resource. Once they're gone, they're gone. So we do look more closely at those. So again, that one's a little bit more variable and will take longer. So I know I just talked about fees, but ATP is celebrating its 25th year anniversary. And so until the end of 2026, we are waiving our data access fees. We still apply the application fee, the biosample fees, and we might have other things, but the data set fees themselves are waived. So if you're interested, now is a great time to take a look at us. And so really we want to know how we can help. So in the initial phase, I think we could really help figure out variable selection, how to optimize your sample size for what you're looking for. Some people request kind of like all of our data sets. You may not need that, and it's just going to add extra cost and complexity. So sometimes it can be helpful to talk to us. We can also help you navigate the application ethics process. Like I said, we can review stuff before you submit. We can do sample size estimates, fee estimates if you need those for grant applications, and we can provide letters of support. We can try to help you with ongoing analysis support, additional data, and sometimes ethics renewals if you need that. And really, we can help you with knowledge translation and promotion as well. So we would love to hear about what you're doing and be able to do social media posts or include it in our website and newsletter stories. We can help you produce infographics and visual summaries, and really just try to promote your work. So please think of us for things like that. And then finally, we also are interested in helping with student projects. So we can either host or co-host practicum students or other summer student projects, or providing data for student projects. So we usually try to expedite those as much as we can. And we're obviously open for any kind of joint projects or collaborations. So I think some common areas of interest for us, especially with you guys, is around the data collection piece. So I had talked to Tyler Williamson a little bit about this, but so we can include sort of open text options on our surveys. And we are interested in this because we could collect a lot of really interesting contextual information that we can't get otherwise. And we're looking to do some work with cancer survivors, so this would be great. The only problem is the amount of time it takes to clean and redact and use that data, which if you guys are using health records and charts and things like that, you already know how this can go. So we're definitely interested in text mining and natural language processing projects and methods. We have a couple right now, but we're always really interested in helping to collaborate. And if we can provide data to test a method or something, we're interested in that. And then again, around data provision and privacy. So, what's considered de-identified, and we're sort of held to the Alberta Health Services identifying policy, which is governed by the Health Information Act, but we're a research study and a health organization. So sometimes that gets tricky. And then really after you combine so much data, which we want to do because we want to enable really comprehensive, complex analyses to understand risk. But when is it no longer considered de-identified when you combine so much data? And then really around data access. And so I had a really good discussion with Tyler about this as well. But, currently we send out custom data sets via like actual data sets via secure transfer. We would obviously love to not do that for a lot of reasons. So we're working with the AHS Snowflake team on the research instance of Snowflake to be able to create that virtual trusted research environment where we can keep the data in one place and people come in and out and can do analyses. So yeah, I think we have a very shared interest there, and we want to have open but controlled access is really the bottom line, and we don't want to be protect the data too much, but we want to protect our participants while understanding that they gave this data to be used. So yeah, let's connect. We're available and around. Again, we want to help you and to use the data. We're here to have the data used. And if there's data you're looking for and we don't have it, then we also want to know about it so that we can think about it for future data collections. We have an ATP research newsletter that will go out periodically with, say, new data that's available or profiling work that's being done. So if you want to get on that list, you can email us at atp.research@cancercarealberta.ca. We're hoping to have virtual office hours coming, and we are located in the Arthur Child Cancer Center. So we are looking forward to hosting people there as well. So thank you. You can visit our general website, and we would really love to thank our participants. I always love meeting participants in the wild who say, I am part of ATP. I think it's an incredible gift that they provide and that they are willing to share so much information and keep participating and making that data available for research. It's just unbelievably generous. I would also like to thank our staff, who are a wonderful group of people, very knowledgeable. So please contact us. We'd be happy to help you. And our funders who have been longstanding and very supportive: Government of Alberta, Alberta Cancer Foundation, Canadian Partnership Against Cancer and Health Canada, and Cancer Care Alberta. So thank you. That was a lot. I'm happy to answer questions. I can stay a little bit after, and I'm happy to meet afterwards as well, or take any questions by email.
Well, thank you so much, Dr. Vena, for this overview. I feel like I have, 10 different research ideas already spinning in my head. There is one question in the Q&A from Christopher that I'll read out, and then anybody else online, please feel free to put your questions in the Q&A or use the raise hand function and we'll call out on you. So the question that we have in the Q&A is, what is the policy for engaging with you on optimizing clinical trial recruitment? So in a trial recruiting cancer patient population for a clinical trial, can we access that data to reach out to cohort participants?
Yeah, I think so. We would usually do that as an ancillary or a sub-study. We get our data through the cancer registry, so I would almost think you'd have a better success rate. And if you're looking for particular cancer types, like it just might be more efficient to go through AHS CCA already. Are you thinking that our cohort participants would be more attractive because they're already engaged in research, or is it because of the past data collection, or is it really just like reaching people with the criteria that you're looking for? I would say so without being able to answer, I guess it's possible. I think we do have to manage those asks quite conservatively, but it's something that we could look at. I think we would just need to understand more about the project and the particulars and what's being asked and that kind of thing. Does that help? Hopefully.
Christopher, feel free to to unmute if you want to chat a little bit more through that.
Oh, sorry. I thought I was restricted. No, that was a great answer. Thank you. It was very much looking to pre-screen ahead of, to reduce participant burden and patient burden. If there's already data there that can, give us information that might meet our clinical trial needs.
Okay.
It was mainly just around the question of consent for contact as well. So I know they're de-identified records, and most of the time it's pseudonymized. But if there was an opportunity to reach out to them through your platform.
Mm-hmm. Yeah, I think it depends on what it looks like. Depends on what it looks like. And if it's, and for other things like other kinds of data collections, like if we want to know about this particular issue with cancer patients, I think send us the information, because again, we are looking to, we are trying to send out surveys every few years, but we're going to be moving to a strategy of sending shorter but more frequent surveys, and these may be more targeted. So, for example, we're looking at the cancer survivors, so we might have some very cancer survivor specific questions, and those would go. So we're looking to develop that strategy. So the more we know about what people are interested in, the more it will help inform that strategy.
No, that's great. Thank you. I'm also based at the Arthur Child, by the way, so maybe I'll run into you in the corridors and can ask you the question over coffee or something.
That would be wonderful. We're in the lower courtyard. We prefer not to call us basement people, but we're in the lower courtyard.
Lower courtyard. Oh, you got that nice little outdoor area to yourselves then. Oh, nice.
Yeah.
Anyway, sorry. Thank you very much.
Thank you.
Great presentation. Thank you.
Thank you.
Another question we have is for the student internships that you were discussing, or student projects. Would that involve the student working with you and your team in person and being supervised by your team, or is that being supervised by another PI, but just using ATP data?
Either or.
Okay.
Yeah.
Awesome. So it sounds like lots of opportunity for students then.
Lots, yeah. If we can host them and if that makes sense, great. If it makes sense for us to co-supervise, great. If it makes sense for us to just send you data and you do it, great. There's lots of ways we can do it. I would say our ability to supervise is a little bit more limited. So if you can supervise, great. But we also have had practicum students that are involved in like data cleaning, or more like almost more like data administration type stuff too. So it really just depends what you're thinking, but lots of options.
Great. Another question we got is, are there any places where the data sets are more available or accessible to the general public, like maybe a dashboard to allow people to make informed decisions or insights about their health? Great question, Ingrid. Thanks.
Not currently. So we're looking to make more summary data available. On the website, just takes some capacity for us to generate the information. I think we're also looking at, since you have to register for the researcher portal, we might put some tools in there so that you still have to register through the portal. So it's maybe not publicly available, but not as restricted. And so you could maybe do some tooling around in there. It just depends on the privacy aspects and how much we can have in there. I think once we're in Snowflake, that will open up some more opportunities, because we could have more of a little like sandbox area where people can come in and even play with a data cut until they refine their research question, for example. I think in terms of improving their health, like more from a personal perspective about what they should be doing, is that what that means?
Yeah, I was just kind of curious. You have all of these participants and getting a benefit from providing their data and seeing what's happening with their health.
Yeah. So we do participant newsletters now twice a year. So we try to showcase how their data is being used, and any findings, notable findings, etc. I think it gets like we've had a few research projects that have done, say, risk calculators and things like that. I think it just gets a bit complicated because those haven't necessarily been more broadly validated with other data sets, etc. So sometimes it's just not quite ready for prime time. Do you know what I mean? And I wouldn't want to go too far too quick. Does that make sense?
Yeah, it does. Thank you for your response.
Yeah. For the diet and activity work, though, for the participants who are doing that, we are giving them a summary report at the end of the data collection. So it'll show, this is what you reported. And these are the areas that you can improve in, and providing some links out to resources for that. So hopefully that will be helpful.
Yeah, thank you.
Thanks.
Okay. So I have a question for just, my own my own works. I supervise a lot of students and also teach courses with a lot of students. So when it's for students accessing data, is there still that data fee for students, or is that something where you maybe would move them to the synthetic data? Tell me a little bit more about that for students, like for a course project, maybe.
Yeah, I think we could do it either way. I think if you want actual data, including link data for a student project, we would have the course instructor as the PI, and they would really be responsible for how the data is used. So you'd want to keep it on your own organization servers, and you would have the ethics file, and you would just change out, who's on that file, etc. But you would really be responsible for it. We may still charge the application fee. I'm not sure. We could decide on a case-by-case basis if cost was an issue. And then for the synthetic data set, you'd be welcome to use that instead if you want to do that. It's a really nice resource that the CAMPath has. We don't really have anything like that now because CAMPath has one. So yeah, I think either option would work. I think our data would be more Alberta specific, could possibly even be a little bit different. Like they don't hold all of our data sets, and we could link it to SPORE data, etc. As long as all the the T's are crossed and all those things. As long as we have the paper trail, we know what's happening with it. I think that's something we'd love to explore, for the data to be used in some kind of student training courses and things.
Fantastic. We have a couple minutes left, so if anybody has any other questions, feel free to drop them either in the Q&A or unmute and chat with us.
And I did see the comment that it would be very nice if there was a scanning necklace that would measure everything that's being consumed. That would be nice. It's very challenging to measure food intake and even activity very accurately. Because even if I followed you around with a video camera or a scale or something, that may alter your eating habit just slightly.
Sure. Okay, well, I'm not seeing any more questions pop up, so I will just give you a big thank you, Dr. Vena, for coming and sharing what's going on with the Alberta Tomorrow project with us, and how we might collaborate with this great data resource. I know I certainly learned a lot about this data that I didn't know previously, so I have lots of ideas swimming in my head. I'm sure many other people on the call do as well. So thank you again so much for your time and for your expertise today.
Thank you.
Yeah, thank you very much.
Thanks,
Jennifer.
Thanks.
Thank you so much, everyone.